Some specialties like surgery for certification require not only a written, but also an oral board exam. So I'm going to walk you through a typical trauma question for an oral board exam. And you guys are going to play along with me and see how you answer these questions. So you have a 24-year-old male who comes in, EMS calls, after a high-speed motorcycle crash. Okay, first question for you is, how do you want to prepare your trauma room? Okay, you want the room nice and warm, you want your airway equipment, you want some blood on standby from the blood bank to be on the way or in the cooler. Again, I want you guys to comment on all the things you would need to set up your trauma bay, okay? So they call and they're on the way. Okay, so the patient rolls into the room. The patient's obtunded and making just gurgling sounds. So what's the first thing that you're gonna do? Well, A, you're gonna intubate this patient. So he's gonna get an endotracheal tube to protect his airway, okay? So in the oral board exam, we want you to be very much by the book and follow ATLS. Okay, B, so what are you gonna do? All right, you're listening for bilateral breath sounds. They are absent on the left. What's your next plan? Good, so you're gonna place a left thoracostomy tube or chest tube. Okay? Excellent. What's next? C. Okay? Patient's blood pressure is 90/40 and the heart rate is 150. What are you going to do? Excellent. 2 large bore peripheral REVs, or in this case, maybe even central venous access. And what are we going to do? This patient's hemodynamically unstable. Class 3 shock because of the hypotension and the tachycardia. Good. You're going to give blood products in a 1-to-1-to-1 fashion. In our shop, we have whole blood. Okay? D. Disability. Okay? So we're going to calculate a GCS, so call it a 3. Or actually, I said he was moaning. We'll give him a 4. He wasn't moving, his eyes were shut, and he was making incomprehensible sounds. So let's call him a 4. So we gave him a GCS of 4. He was intubated. However, we did take note, which is important, prior to intubation about him moving anything. And right now we don't know because he wasn't moving his upper or lower extremities. And then his pupillary exam, well, his left pupil was blown. Okay, that's a problem, right? E, we expose him. And we happen to look at his pelvis and press on his pelvis, and he's just got road rash all over his entire body, okay? So what are then the adjuncts to the primary survey? Fast, okay? So he has a positive fast, all right? And we get a chest x-ray, and we get a pelvis x-ray, okay? On the chest x-ray, we see a left thoracostomy tube. Both lungs are up. On the pelvis x-ray, we see a big, nasty, open pelvis. Next move, pelvic binder. Good. So we bind the pelvis. We have a positive fast, but we also have a blown pupil. Where are you going to go? This is the clean kill on the oral boards. Good. You are going to the OR, my friends, for an exploratory laparotomy to stop the bleeding. Then immediately from the OR, we're going to go to CT. He's got a significant subdural hematoma, and we're going to call our neurosurgical colleagues. Now, some of you are going to ask or say, in a perfect world, yeah, maybe we just go, because this is such a profound physiologic response to herniation. We know the patient's herniating. You know, you'd have to probably twist a neurosurgeon's arm to do a cranie without a CT scan, but maybe some of my fellow TikTok neurosurgeons can weigh in on that. But we have to stop the bleeding first, because without that, this is meaningless. So that's the typical walkthrough of an oral board. There's just so many things that are going to be hitting you from all different directions, and everything's going to be wrong, and you have to correct them, reassess, correct, and reassess. Nice work.